Hi, Dr. Juraj. How are you?
Hello, very fine. You?
Doing good, doing good. Like IDS is busy as always, I guess.
Yeah, really busy. So many people, so many meetings, and so on. Very hectic this year, as a matter of fact, when I compare to the last time, 2 years ago. I think even more people.
More people?
Yeah.
How many times have you been in the?
Well, this is. I've been here a lot.
Let's.
I've been here a lot. I'd say this is my sixth time at the IDS.
Sixth time.
Yeah. I've been coming since 2008, I think. Yeah.
I see. And do you see it changing? Do you see
Yeah,
it like?
I see a lot of change. I see some trends each year, and what is interesting, these emerging trends. For instance, a couple of years back, everything was about CAD cams. Then it was about scanners mostly. Before that, there were implant systems mostly. Nowadays, we are slowly shifting towards novel technologies such as AI and how we could imply them in the clinical office. And it's very exciting to see
Yeah.
things develop.
I see. And obviously you are here as a speaker also.
Yeah,
You're
yes,
speaking for
yes,
GC.
yes.
And can you talk to us a little bit about the lecture or what you're going to be presenting about?
Yeah. Well, first of all, I'm very grateful for the invitation. It's my honor to provide a lecture for GC here.
We're happy to have you, obviously.
Yeah, thank you. First of all, my main subject will be my experience with the GC Alva implant system throughout the years. I've been using it since its introduction in the European market, so it was early 2010, so 2012, somewhere 2012, 2013, and I've had many cases with it. I know its many advantages, also I know the shortcomings, obviously. I've introduced it in many countries worldwide, so more than 10 countries, the introductory lectures, many workshops, hundreds of people went through it. So all in all, I will share my experience in less ideal cases. So the nature of my work is mostly with the grafting cases where there is little or nothing to begin with. Little bone, little soft tissue. But also in my lecture, I always try to emphasize the fact that we need to be minimally invasive. For instance, I really strive and my goal is to remove myself from the equation so that the body can heal on its own. So minimum intervention that is needed in order to get high quality service for the patient at the end.
I see. And you said like you try to remove yourself. Like how do you do that?
How do I? Sorry?
You said you try to remove yourself, and
Yeah,
you
I try to remove myself
how
by
do you
being
do that?
minimally invasive. So using microsurgical approach, for
see.
instance, really making sure that there is no over treatment for the patient, that we are doing just the thing that the patient needs. However, we must be aware that the patient at the end is holding us accountable for white and pink aesthetics only, especially within the aesthetic region. And there, the less invasive we are, the body at the end rewards us with a better outcome if we do a proper technique over there. So yeah, the emphasis will be on these kinds of cases and how the implant performs in these cases very predictably for me. So I'd say that it works well in my hands at least, and from my feedback from the users, also for them as well.
I see. So you told me like you've been using it for more than 10 years, right?
Yes.
In your opinion, what makes this system work? Like why is it working like for like 10 years right now?
If I were asked this question, I would say first of all simplicity. If we want the implant to have a wide base of users, obviously some things have to be more straightforward, some things have to be more complicated. I'd say that the surgical part needs to be straightforward and easy followable for when we want to have a wide base of users. But then again, if you have an easy protocol for the surgery, obviously you need to have a wide base for the prosthetic solutions later on, because many users with different specialties or general GPs, and therefore I think that the prosthetic part needs to be a little bit more developed and complicated. GC provides many solutions in that form, and also I think that the system works well also because of the high quality control. That's my impression, because often whenever I visit an implant company, I like to ask what is the most expensive part of the production. And at GC I got the first answer, quality control. I was not used to hearing this. So
Really?
often you hear like surface treatments or whatever, but then when I asked them to explain the quality control procedure, they told me that each implant is inspected for the connection between the implant and the abutment. And as you do know, the weakest link in implant systems is the prosthetic screw, and it really makes sense to have a safe conical connection there. And I think in the long run that the system performs well in prosthetical sense because of this.
I see. And obviously there are many, like let's say, popular alternatives to this implant system. Where do you see this implant system? Like you said, like probably quality control.
Yep.
But from cases that you've seen, does it provide something that other implant systems like are?
Well, for sure, it is difficult nowadays to say that some implant is above the average. But then again, there are several key points where we can judge this. For me, the quality control is an important key point. Also, the service from the implant manufacturer, the support that they are providing is extremely important, and the educational program that they are offering. So from that standpoint, also implant cleanliness. This implant surface has been shown that from the Clean Implant Company Society, they were investigating many implant systems, and this implant has been shown to be perfectly clean, with a perfectly clean surface. These are some small details that make a difference for me when judging an implant system. So I'd say that we need to be very careful when judging these like premium features that the implant might have.
I see. Something that, maybe relatable to the IDS.
Mm-hmm.
How do you see the field of implantology or like implants develop in the future? Are there features that you think this would be cool to have in implants in the future?
Exactly. When we talk about future trends, I see the far future, which is still very far from us, where there will be biological alternatives to implants, of course. This is what we are striving for one day scientifically. But when we think about implants at this moment, of course, implant design can always be improved. Implant connections can always be more improved, although we are very much on a good track with the conical connection within the implants. Also the surfaces as they are currently and most of the time bio-inert, then they might be changed to have an interplay between a bone graft, for instance, membranes and implants, in order to have a beneficial trait of creating more bone, creating more soft tissues. Also, where I see the advantage is not the possibility of advancing the system is not only the implant surface, it is the abutment surface, where really interesting things are happening lately, especially with the highly polarized zirconia exposed to the epithelial cells. Nowadays, we know that these surfaces might outperform titanium totally. So yeah, there is a shift going on for the last couple of years within the soft tissue compartment for sure.
I see.
But for the bone, I see like more biologically modifying surfaces that are bioactive, for instance. And that can maybe offer us even faster integration.
Yeah. What's the point where you see most implants, like people who do implants and they fail, for example? What's the point that you always see like most common where people miss?
Skipping instances, being pushed by also unrealistic expectations from the patients, especially when I often have cases that are relayed to me after the failure. So this is what I see. Often using implants in an immediate manner when those implants are not indicated in those cases. So those cases should be chosen wisely. What else? People don't pay attention also to the proper design of an implant, where, long story short, what is rough should be exposed to the bone, what is polished should be exposed to the soft tissue. If you submerge an implant with a polished neck, you are maybe asking for trouble as well. So those are the cases where I saw some failures that were relayed over to me.
I see.
And also not choosing the patient wisely. If you choose a patient who clenches his or her teeth, has this big of a muscles, and you place the thinnest possible implant in the molar zone and don't have proper occlusion to begin with.
That just does not work.
Yes, exactly.
Okay, so just one takeaway that you would always have the people who are listening to us to keep in mind. What would that be?
I would say to be strictly biological. And keep, for me, what I always say to the students as well, keep the wide base of knowledge. Maybe this is a bit weird coming from a specialist, but I think that the broad medical knowledge that we possess and then the broad clinical knowledge that we gain before specializing, for sure, makes us really resistant to unrealistic expectations in the future, makes the patients safe from overtreatment, and makes it easy for us to be evidence-based and to discern things that should work and would work
I see.
for the patient.
I see. Thank you very much, Doctor.
You're most welcome.
Appreciate you.
It's been a pleasure.